recording. I know you said you had 8 students join you. Is that right?
Yes, I sent you the
Yep.
attendance report.
We
Okay,
got a quiz today, right?
we do.
Okay, what I was about to ask. I don't remember.
Okay.
Did you ever release out the concept two or week two concepts? Because I saw the week one and I saw like the lecture for week one too, but I
Miss
didn't see the
Miss
concept.
Marvel,
One second, Keel. Go ahead, Jory.
I saw the you posted announcements for the week one lecture, the week two lecture, and then you did the concept review for week one, but I never saw the week two concept review.
Yep, the week 2 concept
So
recording was in the hang on, was in the week 2 announcement, and the week 3 concept recording for this week was in the week 3 announcement. It's always at the bottom of your announcements.
okay, I got you. I just wanted to make sure. I
Yep.
kind of had a feeling I was missing it. I just wanted to make
Well,
sure.
they're all there. All 3 weeks are there. Go ahead, Keel. What was your question?
Michaela Jones asked, could she be let into the meeting?
Okay, I don't have anybody in the waiting room as of right now, but thank you. I'll watch for her. Thank you. So for those of you that were able to attend the concept review in the last hour with Dr. Kopteros, how was it? Can I get some feedback? Please. Lisa's shaking her head.
Helpful.
Lisa.
It was
Pardon me?
very helpful.
Understanding.
It was very helpful because I honestly I still feel really confused um with the reading for the week. I feel like I'm all over the place. So she
Okay.
gave me a better understanding of what to focus on
Okay.
specifically for the quizzes.
Fantastic. That's great feedback. Does anybody else have any feedback that they'd like to add in addition to
Can
Lisa?
can I ask a question about the weekly tutorings? Because I wasn't able to go today because I was in
Okay.
class, but I thought that I did see on Canvas that they're going to be like every day this week anyway. So if I
Well,
go to one tomorrow, is that like next week's information?
no, it's this week. And I'm not sure who can you identify yourself, please?
Lauren Green.
Lauren, can you put your name in the because it's just coming up as iPhone.
Oh,
If
okay,
you
yes.
that's okay. If you could just rename it to you. Dr. Kopteros has offered to do a concept review um, prior to each of the classes that we have in sections all week. Okay, so Monday, Monday we have a section. Tuesday we have a section. Wednesday night we have a section. Friday we have 2 sections in the afternoon and evening. Dr. Kopteros has
Mhm.
offered to do a concept review before the hour before all of those classes. And as I tried to explain in my announcement, you don't necessarily have to go to the one prior to your class, but it is concept review for the week. So, for example, if you go tomorrow, you're probably going to already hear a lot of the concept review,
Mhm.
right? And so it's intended to be given the hour before your class time, but also offered for any student that wants to go at any point during the week.
Okay. Okay, I'll probably
Does
still
that
check it out
help?
tomorrow just to get the
Yeah,
information.
yeah, that's a great question. Thanks for the question. Does
Thanks.
anybody else have any questions?
Yes.
Go ahead.
Dr. Kateros, is your concepts reviews recorded that maybe I could listen to that in case I wanted to a refresher of whatever was before the class, even though I'm in the class now, yeah, to go
Yeah,
back.
they're not generally recorded. I don't know if Professor Marvel wants me to record them. I can if she wants me to.
I mean, you can record them. However, they're not going to get posted until after class because
Right.
they're done right before class, and there's a process that we have to go through to get them uploaded to get a proper link to be able to post in an announcement. And because this is done right before class and we're in class now, all that recording
Yeah.
won't be done and like I said until after.
The only other option I can suggest is
Mhm.
if there are a few of you on the Monday class that cannot make it Monday at 2, and you would like to have one on Sunday in the evening, I can do a concept review
Mhm.
Sunday in the evening.
I think that'd be
Yeah,
good.
that I would appreciate that because we're
Okay,
in
so,
class that from that time.
all right,
So
so
we'll
Sundays at
hang on, hang on. We're gonna have to think about that because we have to make sure the same opportunity. Maybe what we could do is this. If you can't, let's think about this. If you can't attend, if you are not able to attend the hour before your class during the week, there's one concept review that's done on Sunday evening that's open for everybody to go to prior to the week. How does that sound?
Yeah.
Okay.
Yeah. Thanks.
That's a great suggestion. Okay, I will get with Dr. Kapteros and we'll get a time Sunday evening that she'll do an additional concept review and we'll open that up to every student in every set, all the 7 sections. How's that? I think
Okay. And I
that's
just want to add in today's review, it went very well. The students know a lot more than they think they know because I
exactly.
asked about, like say I was asking about rural community, they were bringing up some stuff that was
Yep.
very specific to the quiz and they already knew it. I didn't have to, so they were prepared for class.
Yeah, that's awesome.
Thing that we did cover was test taking technique. So we went over like how to approach SATA questions as true false questions rather than comparing. I never compare my questions with each other on a select all that apply. I just do them as true and false. And then how to prioritize anything that says new onset. You want to make sure you jump on that between prioritizing isn't just ABCs, it's chronic versus acute also. So things like that came up also, and I just wanted to let you know that, Professor Marvel.
That's awesome. That's awesome to hear that the group you had was very well prepared for class. That's awesome. And I do believe when you say the students know a lot more than they think. They do. They do. I really believe that. So the way the class is structured, Dr. Kapteros has come on this term to be a co-instructor with me. Okay. We both have Monday and Friday classes. They're double sections. Okay. We have a lot of students in each Monday class and Friday class. Dean Brown asked us to conduct the class together. Okay. And we just used my Zoom. Okay. So Dr. Kapteros, after the class, gets the attendance, gets the recordings, and then we both post them in our sections. Each of us has some of you students, the other one has the other group of students. Dr. Kapteros and I agreed that to give her some teaching experience, we would split up the teaching. So I'm going to be teaching the Monday class, the double class, and Dr. Kapteros is going to be teaching the Friday class. Okay. But Dr. Kapteros, like I said in my announcement over the weekend, has taken over the class with regards to grade book and everything, tutoring, review sessions, everything that goes along with it. The difference is I'll be teaching the class, but she is obviously present and will add to the lecture, add any additional information that she would like to add during the class time. Does that help clarify?
Yes, can I say something just to know that I understand? So any question we have, we can text you and Dr. Kapteris. We can text both of them and ask for answers if we need help with
Well,
anything.
if it has any, if it's outside of this particular class time, then it should go to Dr. Kapteros,
Okay,
right? I
okay.
mean, the only difference for this class is, are we able to go to both classes? What does that mean? What do you mean?
Monday and the Friday.
Like, can we sit in on like a Friday lecture when Dr. Coteros is lecturing?
Absolutely.
We'd like to hear from two different perspectives per se.
Absolutely. Absolutely. You can sit in on a Friday class. Sure.
Great idea.
Sure. Yep. Any other
I
questions?
think I'm gonna do that too. If try to sit on a Friday class. What time is the class again? Do you mind if I ask?
4 p.m.?
4 p.m. Yeah, I think I might do that too.
Okay. Fantastic. Okay. And the other thing that Dr. Kapteris and I we can meet after is maybe we could come up with some kind of well, actually, that's kind of what Dean Brown asked us to do. She asked that Marvel teach the Monday class, Captero teach the Friday class. That's what she asked us to do. And that way, Dr. Capteros can listen in on Monday, and obviously prepare accordingly and teach the Friday class. So the same thing is happening with just so you know, the same thing is happening with the Friday students. Even though I have a group of students in Friday, Dr. Kapteros is teaching all of them. So my Friday students, it's just reversed for the Friday class. Okay, they'll be hearing lecture from Dr. Kapteros. Does that make sense?
Yes,
Yes,
so if we go
yes.
to the Friday class, do we have to pop in for the Monday class for attendance or
Yeah, you have to come to the Monday class for attendance.
Gotcha.
Absolutely.
Okay.
Yep, yep. And Friday is just your voluntary need or want to sit in on
Gotcha.
an additional class. Yeah.
Okay. Got it.
Okay. Does that help?
Yes, thank you for explaining. That makes it easier to
Okay.
understand.
Great, great. Okay. Let me just check the chat. I've got 5 messages in here. Let's see. Michaela having problems with her audio. Did that get sorted out, Michaela? Okay, if you try to open the quiz prior to 15 minutes ago, you're going to have to refresh. Okay. The access code for the quiz is my last name. I'm going to put that in the chat. I just put in the chat.
Is it a certain time we should return?
I haven't got there yet. Hang on, Keel. I'm
Okay,
just
my bad.
hang on 1 second. Okay. So let's see. It's 3:15 or 3:14. We will be returning at 3:30. It's a 15-minute time quiz. So if you get going in the next 2 minutes, you should be ready to go, ready for lecture at 3:30. All right. So go ahead and get that started. Make sure everybody's on mute. Please stay on camera. You can go off camera after you finish the quiz and submitted it. Okay. Does anybody have any questions?
No.
Okay. So go ahead and get started.
I'm sorry, Miss Marble. I had got kicked out. Is the password your last name?
Yes. Yes.
Okay.
Yep. Okay, it looks like everybody's done. If everybody could come back on camera, that'd be great. How'd you do?
Really good.
I did better.
Yeah,
Much better this time.
yeah, I saw the majority of students had
Much
improved.
better.
Yeah, much better. Exactly. Okay, what did you do differently between last week and this week?
I watched your YouTube recordings.
The concept
Watched your
recording.
YouTube.
Yeah,
Yeah,
concept
concept
review.
recordings and reading.
The concept recording that was given in your weekly announcement.
Yes.
And okay. And that was different from week 2 and 1.
Yeah. Yeah, it just made a difference. I kind of like just psyched myself out the last week. So I just took my time a little more.
Good, good. Well, there's a reason we send out those weekly concept recordings, right? Because in those concept recordings, you got an overview of the concepts, right? And also those concept recordings cover quiz information, not quiz questions, but certainly quiz information. Did you find that? Yeah. Yeah. And then, as a added bonus for you this term, Dr. Kopteros is doing this concept review before class. So you're getting really a double concept review, right? So good. I'm glad most of you improved. I hope the resources that we are giving you prior to coming to class are helping give you an initial overview of the concepts.
I haven't taken one of your exams yet, but so far the stuff that I heard that I was kind of like tripping out about beforehand doesn't seem to really be a factor here. Not that I'm seeing.
Okay. And as far as exams go, just an FYI, the reviews that are done this week cover the content that you're expected to know for the exam. And you'll find that most of what we're covering in the reviews is a repeat or just going through what we've already covered in class. Okay, so if you can't get to a live review this week, you'll get the recordings, and I would appreciate it if you would try and take the time to watch the recordings. Okay, they're going to give you a good indication of what knowledge is expected. Because, of course, in the class, we cover concepts as a whole, but in the quizzes, we cover questions are about, certain knowledge within those concepts. We try and pull out what is the most important knowledge about each concept that you need to know.
And can I ask a question?
Sure, Lauren.
The exam review is at 10 o'clock tomorrow.
I'd have to go back and look at the calendar. I don't have it memorized. I know I know when mine is, but you'd have to go back and look at the master calendar that was sent out in week 1.
Yeah, that's what I looked at. I just wasn't sure if it was actually 10 p.m. It said 10 p.m. if it was.
It says 10 p.m. on it?
Yeah, let me go back and look.
It's not a 10 p.m. If it's a 10, it's a 10 a.m.
Okay. Let me hope.
Yeah, if you could just clarify that for me so I can, if I have put that incorrectly, I want to send out a.
Hey, yes, I'm looking at the calendar right now, and it do say 10 p.m. on 10:15.
Yeah.
Maybe okay. Let me check. Let me double check with Professor Ford. Maybe it is 10 p.m. I mean, I thought I had it correct, but let me confirm that with her. Because she approved what I sent, so maybe it is 10 p.m.
Okay.
Okay.
But if it's recorded, then I don't know. It was recorded. I'll check out the recording one, and I was going to still go to yours on Friday.
Okay. Yep. And mine's Friday at 6 p.m. after our Friday class, right after. Okay. So let's go through the quiz. We'll review. Everybody saw the rationales I put in. Again, the rationales are directly, it's a good start, a good overview for each of the concepts. And after we have gone through the quiz, I want to go through some additional information about each of the concepts that's not covered in the quiz. And then the last thing we'll do, probably the last 15 minutes of class, is we're going to do a case study. Okay, and that was in your announcement, week 3 announcement. There was a migrant and farm worker case study. Okay, so we're going to pull that up, or you're going to pull that up. I'm going to break you out into 3 groups. We'll go into the breakout rooms. Each group will answer a question. There's 3 questions in the case study. Okay, and then we'll come back into the main room and each group will talk about their answers. Okay, and we'll go through some rationales for your answers in the case study. So that's how the next hour of class is going to go. Does anybody have any questions?
Do you mind if I log in through my laptop since we're gonna be breaking out in groups so I can see it, everything bigger? I'm gonna log into my laptop.
Pardon me?
If I can log into the laptop for Zoom since we're gonna be in breakout rooms, so my screen is bigger versus my phone. I'm gonna do that right now if that's okay.
Okay, yeah, of course. All right, let's go into the quiz. Okay. Okay, can everybody see my screen?
Yes.
Thank you. Okay, so rural communities, what should the home health nurse anticipate about clients in very rural communities? So as you read your reading about rural communities and you listened to the concept recording for an overview of rural communities, did everybody come up with the answer A?
Yes.
Yes. Yes.
Okay. We know, I'm jumping to the rationale real quick first. We know that rural adults are much less likely to prioritize their health or engage in preventative activity. They're more likely to smoke, have higher rates of alcohol and obesity, less likely to engage in screenings and in wellness visits. That could include blood pressure checks, cholesterol checks, pap smears. Okay. They are much more likely to have chronic diseases in the rural communities. COPD is an example, hypertension, diabetes, arthritis, cancer, right? We know that nearly 50% of all rural adults have been diagnosed with at least one chronic condition. Okay, and that's double the 25% of non-rural adults. That's a large number. 50% of people who live in the rural community have at least one chronic condition. Okay, chronic disease management in rural communities is a huge, huge issue. Okay, so that was the answer. The rural population is much more likely to have complex chronic illnesses. We know that B is actually the opposite. Most of them will have employer provided insurance. That is not correct. Most of them actually will not. Because if you think about a lot of the jobs in the rural community, these are sometimes these are hourly or daily paying jobs. Okay, they don't come with the premier medical insurance, dental, vision, 401k, pay time off. And we'll talk about this later, but one of the issues you find in the rural community of why they're not focused on preventative care or even screenings, and we don't typically see them until they're much sicker, is because they can't afford to take the day off, right? They can't afford to take the week off. They wait till things get bad enough where they have to take the day off. But a lot of these jobs in the rural community are very low paying, hourly, daily wage jobs that don't come with health insurance. And I would apply that also to the migrant farm worker. Okay. They will be less likely to have environmental chemical exposures. Why is that incorrect? What happens in the rural farming communities?
They'll be more likely rather than less.
Much more likely. Because think about all the chemicals, the exposure that they have in those communities. A lot of agriculture, a lot of spraying for pesticides. Okay, they're much more likely to have environmental chemical exposures. And then why is D wrong? What did you learn about rural communities in your readings and recordings?
They don't have adequate access.
So adequate.
Yeah, they don't have adequate access to physicians. What are we looking at? What are we looking at for healthcare coverage in a rural community? Lindsay, you're on mute.
I was just saying, what do you mean by that? Like,
So So what might they have access to? Maybe a primary care physician or a family physician. That's it,
Yeah, that's
right?
about it.
That's
Mhm.
it. There's, and some of you may live in the rural community or have family members that live in the rural community and visit the rural community. I live in a rural community. I'm up here and way up in northwest Wisconsin and up by the Canadian border in a very rural community. Okay, there's nothing. Okay, there's a practitioner. You have to drive 30 minutes to find urgent care, emergency room, anything like that.
And
Okay,
they might have lack of trust in medical health professionals because they don't know
absolutely.
much about it.
Yeah, we're going to talk about the barriers for rural healthcare, but just so you know, there's very limited access to healthcare. Okay, it's not that it's not available, it's just not available in that immediate rural community, right? Like I said, you might have a practitioner, a nurse practitioner, or a PA or a general physician, right? That has to deal with everything. Okay, there's no specialty. There's no high risk OB doctor. There's no cardiologist, neurologist, any kind of specialty. You have to travel for that. And we will talk about the barrier. That's one of the big barriers is transportation in the rural communities. Okay. So here's a primary, secondary, tertiary question. And what I put in the rationale was what I reviewed with you last week, but I wanted you to have it in a rationale so that you can go back to it if you need to, if you have a hard time understanding primary, secondary, and tertiary. So before we answer the question, let's review it. Primary P is prevention. We are trying to prevent something before it happens. Secondary S is screening. Okay, we're trying to early identify, early treat any kind of risk. Okay, trying to prevent complications, trying to reverse the course. Tertiary T is for treatment, okay, or management. They have to have something, an injury, an illness, a condition, a disease, a new diagnosis, right? And then we provide tertiary interventions to help them manage whatever has happened. Okay, so now let's go back and look at the question. A nurse is developing a primary prevention program for members of the rural community. Which intervention would be appropriate? Does everybody understand why B is primary?
Yes.
Yes.
Right?
Because they work out in the salon and they work
is it be-
outside.
Pardon me?
Because I think I got this one wrong, and is it because the pap smear, that's screening, right? Is that screening?
Yeah, pap smear is screening. Yep.
That's why I got that one confused. I was
Yep.
just asking.
But by providing information on minimizing sun exposure, you're trying to prevent something before it happens, right?
Yes.
As Lindsay just mentioned, pap smear is screening, right? What's C? Educating families on diabetes-related foot care. What's that?
Tertiary, because they already have it.
They have diabetes. Exactly. What about D? What's D?
Secondary.
Why?
Screening.
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 Screening. Okay, does anybody have any questions about that question? Because this is starting to build, this question is beginning to assess your knowledge of being able to know what the difference is between primary, secondary, and tertiary. So as I told you last week, there are primary, secondary, and tertiary questions going forward on all the rest of the quizzes, and there's several on each exam, and there's several on the HESI. So we have to have a good understanding of this. And this question just applies to rural community, but we need to be able to apply these interventions in all of the vulnerable populations that we're talking about during this term, okay? So if you want to bookmark question 2 on exam 2, if you need to go back and review primary, secondary, and tertiary, question 2, exam 2 gives you the overall rationale, okay? Question 3. Now we're talking about a migrant farm worker. They report to the outreach clinic complaining of bilateral eye irritation, throat irritation, cough. Which nursing intervention is appropriate? So when you read this question, before you even look at the answers, what are you thinking What's common? What's a common risk with the migrant farm workers?
I'm just thinking about
Chemical
hypersensitivity
exposure.
because it sounds like an allergy.
Allergy reaction?
Chemical
Or
exposure.
I was
chemical.
thinking like
Pesticide
chemical
exposure.
sun exposure.
Pesticide exposure. I covered that in my concept recording, and I'm sure Dr. Capteros covered that in her concept review today. One of the most common risks for the migrant farm worker is pesticide exposure. Okay, and these are common symptoms of acute pesticide exposure: eye irritation, throat irritation, cough. Right. So the appropriate question would be asking them if they have had exposures to pesticides at work. Okay, this is more than conjunctivitis. Okay, we do not treat. So requesting a physician's order for an antihistamine, we don't treat. Okay, so that's an inappropriate answer. Okay, and these are not signs and symptoms of, we wouldn't be completing a TB screening. First, we need to think what these common symptoms are and think a pesticide exposure. And you're going to get asked about this on the exam. So we need to understand the difference between what an acute and chronic pesticide exposure looks like. And that is in your rationale. So please know this. Okay. For a pesticide exposure, very common in the migrant farm worker.
Nausea.
Pardon me?
Sorry.
Oh, that's okay. Acute. Okay, we think of acute memory loss, difficulty concentrating, mood changes, abdominal pain, maybe some nausea, vomiting, diarrhea, skin rashes, eye irritation, throat irritation, headache, confusion, twitching muscles. When we think of chronic, we think of long-term exposure, right? That's the difference. Acute is the happening here and now. Chronic is over time. And there's a big difference with regards to long-term pesticide exposure. Okay, so if the question had asked, given the symptoms of maybe neurological issues, Parkinson's-like symptoms, maybe diagnosis of cancer, those are long-term effects, all right? These are long-term effects of long-term exposure. So birth defects, cancer, blood disorders, neurological problems, and reproductive effects. Okay, maybe Parkinson-like symptoms, infertility, sterility, liver damage. Those take time to develop. And that's why they're listed as chronic symptoms or chronic issues with chronic exposure. Okay. So again, please know the difference between acute and chronic. You'll be given a scenario and ask, is this a chronic exposure or is this an acute exposure? Okay. Questions about that? Okay, another question about migrant farm workers. One of the things we know about in the migrant community is often they are living in very crowded housing. Okay, what risks does very crowded housing bring?
TB, tuberculosis.
All those respiratory infections, viral infections.
Exposure to hepatitis, exposure to TB, right? Exposure to just disease in general, right? So that's what this question addressed. During a home visit, the nurse notes the migrant farm worker is living in small houses with several other family members. What nursing assessment is a priority? Okay, so that's the key word here. So this is another example. We had a couple of questions last week. This is not a select all that apply question. So if more than one answer looks correct, you've got to go back and reread that question and say, maybe I missed a word in there. And that word would have been priority. So a very high risk in crowded, unsanitary places where migrants live, there's a very high risk for TB. So the priority would be to do that symptom screening questionnaire for TB. Okay. And actually, the other answers really don't make a whole lot of sense. Assess too in the consumption of nutrient dense foods. Yeah, I guess you could assess for that, but that's way down the road, right? Ability to travel into town for healthcare services. That is nothing. It really doesn't have anything to do with crowded living conditions. History of GI reflux, maybe, but that's way down the road, right? We need to look at what's a priority. And when we just think of look at the population in the question. Okay, we're thinking migrant farm workers. There's a lot of hints in that question. Migrant farm workers living in small houses with several other families. So then you need to think, what would be the risk in that situation? And this is a good rationale about migrant farm workers. I mean, there's more information to follow, but this is a good start, right? So when migrant farm workers arrive to work, they may find that housing is not available, or it's substandard, right? Maybe you have sanitation issues, structural issues, maybe exposure to mold, exposure to lead, maybe has broken appliances, lack of heat or air conditioning, right? Some migrants will live in cars or tents. When housing is available, it tends to be overcrowded, right? Which contributes to TB, gastro, GI issues, hepatitis, right? We know that older housing exposes residents to lead, right? And we also know that housing may be located next to fields where high concentrations of pesticides, herbicides threaten the health and the families, where children are also at risk, right? For pesticide exposure from injury. Let's say the kids are working on the farms, right? Younger kids are working on farms. They're much more at risk for accidents or injury. Okay. Okay, this is poverty. We covered four concepts this week: migrants, rural, homelessness, and poverty. This is a poverty question. Okay. Which statement reflects the income of health outcome, impact? Which statement reflects the impact of income on health outcomes? Okay, so considering one of our concepts is poverty, would C make sense? Low income increases the risk of chronic illnesses. Why is that the correct answer?
Because they don't really, I guess, have access to all of the like specialty doctors and resources. Yeah.
Exactly. Right? What else?
They may not be able to afford going to the doctor.
Exactly. Yep. What else?
Or they can't afford treatments either.
Mm-hmm.
They might not live in very sanitary or, places.
Mm-hmm. Mm-hmm. So the message is that poverty does have a direct impact on health, right? I mean, just think about in general. Forget even being in this class, just in general. Think of people that live in poverty in your community. Think of all the additional risks and additional challenges they have. And that's what the rationale goes through. Poverty leads to chronic stress, mental health issues, high rates of chronic illness, higher infant morbidity and mortality, shorter life expectancy, more complex health problems, more significant disability related to those chronic illnesses, higher rates of hospitalization. We know that complex health problems lead to higher healthcare costs, right? Which then lead to more challenges financially for that individual or family. And we'll talk about poverty in more detail in a minute. But low income definitely increases the chronic illness. And look at the other answers. So, low income guarantees access to Medicaid. No, it doesn't. You have to have there's a formula. Low income doesn't guarantee. Let's say you're right above the poverty line. Okay. And there's a question about that, right? High income reduces the attendance of wellness visits. It's just the opposite. Higher income increases the attendance of wellness visits, right? And then high income, the last answer, high income does not improve health outcomes. Yes, it does. High income will provide you the resources to get the necessary primary or secondary or tertiary care that you need. It will improve health outcomes. Any questions about that question? Does that make sense? Okay. Okay, here's the question about the poverty line. Which should the nurse anticipate for a family living just above the federally defined poverty line? Well, what happens? What happens if you're below the poverty line? You qualify for lots of different resources, right? But let's say you're just a hair above that poverty line. You fall off. You fall off.
Ms.
Eligibility
Marvel, I
for,
sent you a chat.
pardon me?
I sent you a chat. Could you check it, please?
I can check it after. Okay. Where was I? Poverty line, right? Once you get above that poverty line, even if it's a hair, you're going to lose a lot of opportunities for resources, right? So which should the nurse anticipate for a family living just above the poverty line? Okay.
Increased vulnerability because they're still kind of like don't have a lot of money.
Yeah, exactly. Increased vulnerability due to fewer resources. You have already met the threshold.
Yeah, because you're just right about that.
Yeah.
Happens to me all the
Yeah.
time. Yeah. And then
I
you
had a
lose
student a
your
couple of terms
Medicaid.
ago when we were talking about this question. She popped in and she gave her personal situation. And she said, for years I've lived below the poverty line and was eligible for all these resources. She said, but since I started working an extra shift a week, unfortunately, to provide for my family, unfortunately, that put me a hair above the poverty line. And all of a sudden I wasn't eligible for these resources. Okay. So, answer B, improved health outcomes compared to those in poverty. No. I'm sorry. Reduce vulnerability to employer provided insurance. Okay. That's actually increased vulnerability. And unchanged health outcomes, no, you are going to have changed health outcomes. Okay. If you're living just above the poverty line. Okay. So this rationale is about how the poverty line is assessed. All right. It's defined by the federal government and the various state governments for the purposes of program qualification. Right. And there's a statistical formula way that you qualify. And then it gives some additional statistics. Okay. Programs for those that living in poverty. Here's some examples: TANF, public housing, food stamps, Medicaid, WIC, maybe Head Start. Once you get above the poverty line, right, some of these you become ineligible for those. Okay, so those living just above, I'm looking at the last sentence here, those just above the line still desperately need the help but no longer qualify, and therefore their vulnerability increases. Right? Okay, which client is at the highest risk for adverse health outcomes related to poverty? So it's asking which particular age group, which client is at the highest risk. And in your readings and in my concept recording, and I'm sure Dr. Kapteras just went over this, we know that children, look at the rationale, young children are at the highest risk for effects of poverty. Children. And to boot, this 15-month-old doesn't even have a medical history. Okay, so we don't know if they've been immunized. We don't know if they have What the first 15 months, have they had any injuries or illnesses? Do they have any health issues? Okay. It's not that the others are not at risk. Okay. The 19-year-old with a history of asthma, sure, they're at risk. 68-year-old female with type 2, sure, they have some risk. They have a diagnosis of type 2, right? And then the 44-year-old working on a farm, well, working on a farm puts you at risk anyway, right? But the question was asking who is at the highest risk, right? So it was a priority question in which you had to pull out a keyword or a phrase. But when we talk about poverty, let's look at the rationale. Young children are definitely at the highest risk for effects of poverty. They may lack adequate nutrition, poor brain development, exposure to environmental toxins or risks. They're at risk for trauma, abuse, maybe low quality daycare. Remember, these are kids living in poverty, okay? They have more chronic diseases. They have more nutritional deficiencies, more maybe growth and development issues, developmental delays. They may have higher incidences of elevated lead levels if they're living in older housing. Definitely have more infections, usually, and they're usually stuck in a poverty cycle themselves. Pardon me, due to decreased opportunities for education. I saw this in the schools for 20 plus years. The risks for kids. Okay, especially the risk for the kids of the families living in poverty or the families that were homeless. The kids were much sicker, much more impacted, just didn't have the resources to work through all of what was going on. Okay, so the point I'm trying to make is children are this whole group is at risk in here, but children are at the highest risk. Okay. And even, you know what? The elderly at risk for sure. But if the elderly, the 68-year-old, just because of their age, yes, they're at risk. But the point is children are at the most risk. Okay. Okay. So this is another poverty question. It's talking about the impoverished adolescent. Okay. So increased risk of dropping out of school. Okay, we know that poor teens living in poverty, are more likely to have below average academic skills, and they are actually 3 times more likely to drop out of school. They have higher rates of teen pregnancy, and if they are pregnant, they have much higher risks of complication from that pregnancy. Okay, maybe due to lack of prenatal care. They have a higher risk of low birth weight babies, premature babies, babies with birth defects. So what we would expect from a teen living in poverty is the increased risk of dropping out of school. That's one of the most common risks. And if you didn't listen to the concept review or go to the review before class, let's just look at these answers in general. An impoverished teen, would they have a reduced risk of unintended pregnancy or an increased risk? Increase. So A doesn't even make sense. If we are working with an impoverished teen living in poverty, do you think they'll have excellent use of coping mechanisms, or do you think they'll have challenged use? Challenged, right? And improved attendance at extracurricular activities. No, they don't have interest. They don't have interest, right? So the only logical answer, right, would be increased risk of dropping out of school. Any questions on that? Which client is at the highest risk of homelessness? So let's look at this. This rationale is an excellent summary of homelessness. Okay. Homeless does include those living on the street, but homelessness also includes those people staying with friends or relatives, staying in temporary shelters, staying with institutions temporarily they don't have anywhere to be discharged to, right? So even living with friends or relatives, even when they leave there, they don't have a permanent address to go to. Okay. Some people live in phases of intermittent homeless where they're in and out, right? So because of this, it really truly is hard to assess accurately the number of homeless people, right? We know the homeless people are exposed to elements, right? Maybe cold, heat. They live in crowded living conditions, unsanitary, have improper nutrition, malnutrition, lack of sleep, chronic stress. They're much more likely to abuse substances and have mental illnesses. Very at risk for experiencing TB, skin and infestations. And chronic illness is a big issue with homeless. Okay. They have an increased risks of being victims of crime. Okay. Trauma is a major issue with the homeless population. Trauma is actually a major cause of death and disability due to the violence within the homeless population. Maybe gunshot wounds, stab wounds, head trauma, suicide attempts. Okay. And this is incredible, this last sentence, and this comes from our readings. The average life expectancy for a homeless individual is 44. That's pretty incredible. Okay. So let's look at the question, who's at highest risk? Okay. B is obviously the correct answer. Why is B the correct answer? What gives it away in the answer?
Because he's living alone.
Living alone, right? Because if you look at the rest of the answers, there's some kind of support there, right? The substance abuse, an adolescent with substance abuse has a supportive family. Somebody with schizophrenia is living in a group home. Okay, the older child with a history of suicidal ideations. Okay, the veteran with PTSD living alone is extreme risk. Okay, so everybody understand that. Okay, now you're working in a homeless shelter. Okay, so we know the environment is a homeless shelter. The population is the homeless. Okay, which clients should be prioritized? So again, important word, prioritized. It's not that all of these clients don't need to be seen. It was kind of like the question last week about the school nurse, right? Who needs to be seen first? All those kids need to be seen, but who needs to be seen first? Okay, so one of the high risks in homeless shelters, and we just went through it in the last rationale, is the risk for TB. Okay, so A, complaining of night sweats and unexplained weight loss are symptoms of a potential TB outbreak. Okay, so that is what needs to be prioritized first. Do we have a potential outbreak of TB going on in a homeless shelter? It's not that B, C, and D don't need to be dealt with or treated, but the question was asking prioritization. And A, since it is potentially symptoms of TB, we got to figure that out first, right? Do we have any kind of a TB outbreak in a homeless shelter? Physicians should test for blood-borne infections. This is in the shelters, such as HIV, hepatitis B and C, alcoholism, human, HIV, and length of shelter residence, however long you're in the shelter, increases the risk of TB outbreaks. Okay. So again, it's not that everybody doesn't need to be dealt with. They do. But the question was what needed to be prioritized. Questions? Want to go through a little bit more additional information. Let's see what we haven't covered yet. Okay, so we're talking about the migrant farm workers. Okay, so rural migratory and seasonal agricultural workers. What does a migrant farm worker look like? What kind of barriers might they have? Language barrier?
Language.
Pardon me?
I said language.
Language barrier, not understanding our healthcare system, reluctant to go and get help, right? Barriers preventing migrant farm workers from receiving healthcare and healthcare coverage. Here are some common characteristics of rural. I talk about rural populations and migrant farm workers because there are a lot of similarities. Okay? So we know that going back to the migrants, we know that these are people who come for short term. Okay, they're mobile. So if they go and get seen because of health issues, it's highly unlikely that their medical records are going to travel along with them. Right? That's one of the barriers. Language barrier is another issue. Okay, how do you work with a population if you don't understand the language? They have a hard time communicating if health issues are going on. Okay. One of the things that is also an issue is literacy. They may speak the language, but they don't understand. Health literacy is a big issue with vulnerable populations. Okay. We know that migrant workers come to the U.S. during necessary seasons, and then they go back home. They're moving around a lot. I just mentioned that. They usually do not know what services are available to them. Okay, they do a lack of transportation. Female migrant workers are very much at risk for sexual exploitation, sexual harassment, sexual abuse. Kids are very exposed if they're, a lot of migrants bring their family, bring their kids to work on the farms. Kids have additional risks working on the farms. Accidents, nutrition, they've been pulled out of school. Maybe they don't have the proper immunizations. They're very at risk, right? We know that with migrant farm workers, our food supply in the US would collapse without our migrant farm workers. Would you agree? Yeah. It's estimated there's 2 to 3 million migrant farm workers in the US each year. We talked about the housing. We talked about the risk for chronic diseases, but migrants are also at risk for dental issues, poor health, obesity, depression. They have a lot of mental health issues, the stress of the jobs they're working, right? Of taking their families with them and the stress of all the family members. We talked about risks for malnutrition, infectious disease, pesticide exposure, injuries, disruption of school for the kids. Hey, there is what we call a Migrant Healthcare Act. Okay. These are centers. The Migrant Healthcare Act provides, there's approximately 160 migrant healthcare centers around the country. They're in approximately 42 states, and they deliver healthcare to over 3 million migrants. Hey, what if you don't live in one of those states that has one of those migrant centers? If you do, great, right? They're federally funded clinics, and they do provide healthcare for the migrants. Okay, but only, they serve a certain amount of the population of migrants, but do not serve all. Okay. We talked about pesticide exposure, knowing acute and chronic, rural populations. We talked about vulnerability, less likely to prioritize their health and engage in preventative activities, less likely to see medical care. We talked about the shortage of health or health workers in the rural setting. It's really hard to recruit healthcare workers, physicians, nurses, any kind of care worker in the rural settings. Very hard to recruit. Okay. When the population, when they get sick, they have much more difficulty maintaining their independence because they may not make it to all of their appointments. So the distance between home and various services becomes a challenge. Maybe they can't get there. Maybe they don't have any transportation. There's no public transportation in the rural settings. There's no buses or trains. Okay, so maybe they have no transportation.
I have a question.
Yep, go ahead. Go ahead.
Why would you say it's hard to recruit somebody to work in those areas?
It's hard to recruit people to work in those communities because of the challenges of being responsible for so many in the population. I mean, you could be taking care of anybody across the whole lifespan, right? The pay is not as good as the city. Okay. You are really kind of out there on your own. You don't really have a support network of coworkers. Okay. And if you look in your module under your, I think it's rural population, if you look at that page, there's several graphs of all the areas in the country that have of the coverage, the healthcare coverage. Did you see that, Heather, in your reading? Of how difficult it is to recruit, Heather? Did you see some of those graphs of how difficult it is to recruit and the so many areas that have limited coverage?
I did not actually. I was just asking if I was like a generalized question.
Yeah, no, look at the reading page in your module about rural health and recruiting. And it gives these graphs in purple colors, and it identifies all areas across the country that have difficulty recruiting healthcare workers. It is very difficult to recruit in the rural communities. I think we covered what I wanted to cover on homeless, and poverty. Think about contributing factors to poverty, unemployment. What are some other contributing factors to poverty? What do you think? What contributes to poverty?
Lack of income, lack of education.
Yep. What else? Yep.
Loss of
kids,
pension.
Yep.
lack of support.
Yep. Talked about young kids being very at risk for the effects of poverty. Talked about the teens. And I think I covered homelessness, what I wanted to cover with homelessness. Okay. So that's an overview of your four concepts for today. We covered a lot in the quizzes and some additional information after the quizzes. I want to go ahead and break you out into 3 groups. And somebody in your group needs to pull up the case study that was sent to you in the your week 3 announcement. There's a case study that has 3 questions. I'm going to break you out into 3 groups. Room 1 will answer question 1. Room 2 will answer question 2. And room 3 answer question 3. We'll take about 5 minutes in the breakout room. Then the last 5 minutes of class, we'll come back and talk about the correct answers and why they're correct. This is actually a really good case study. It reinforces what we talked about today about migrant and rural health.
I have a quick question real quick. This might be silly, but I've never went out into a breakout room. How does that work?
So I'm going to be putting you in a breakout room. You don't have
Okay.
to do anything. And then
Okay.
I'm going to be closing the breakout room. And then you'll automatically be coming back into the class.
Okay, thank you.
I
Okay.
cannot access the case study. It says access is denied whenever I click on it.
Same thing with me.
The case.
Is it the healthy people case study?
No, it's in your announcement. It's not in your grade book. It's in your announcement.
Yeah, mine says access denied as well.
Same
In
as
your
well.
the link from your announcement.
Yeah.
Yeah, it's not letting us
Yeah,
get
that's
in.
correct.
Okay. Then you know what? Then what we're going to do, hang on, let me close that out. Then was anybody able to access the case study?
I can
You can?
on my phone, through my phone though.
Okay. Was anybody else able to access the case study?
I can.
Okay, that's strange that some of you can, some of you can't. So I'm going to change my
can.
plan here, and I am going to, we're going to do the case study together. Okay, as a group. All right. Okay, let me share my screen. And this is the version of the case study that has the rationale and the answers. Okay, so let's see. Go ahead and read the case study up here. Oh, wait, starting here. Okay, so go ahead and read from here down where it says the case study. So we have an employee who's scheduled to work in a rural health clinic. She has a particular population she's working with, Hispanic. Okay, and the population is primarily male. Okay. She serves the town is approximately 45 miles away from the nearest densely populated. Okay. Her clinic is in a farm residence in the farm area. Right. Many of the large farms have housing quarters known to be occupied by undocumented workers. Farms are situated within fields of grapevines and peach orchards. Okay. So as a public health nurse, and Heather, this will help give further clarification to your question about working in the rural community. As a public health nurse working in a rural practice, what are some of the professional challenges that she, as a healthcare worker? Okay.
A, C.
Well, what are
A.
some of the challenges? The answer is C. She's actually going to get A, right? She's going to be in a diverse clinical experiences because she's working with she could be working with kids, adults, elderly, right? So she is going to get the diversity in clinical experiences. She is going to develop close relationships with clients and coworkers, right? Because it's only her. Okay. D, she will have greater autonomy in practice. She's the only one. She is much more able to be autonomous, meaning making her own decisions about what's going on in the community. But what she will lack is the resources with other health care professionals to interact with. There may not be a co-nurse with her to get a second opinion, right? She may have to call to the 45-mile, wherever the nearest populated environment is that has healthcare. Okay. So there is a lack of resources, and that's what the rationale explains. Okay. Some of the challenges of rural practice are professional isolation, limited opportunities for continuing education, lack of other kinds of health personnel or professionals from whom he or she can interact with, heavy workloads, the ability to function well in several clinical areas, which she needs, lack of anonymity. She's the only one there. So one of the issues with rural populations is there is no privacy. Everybody knows everybody's business. Everybody knows what everybody's doing, right? And she may even have a restricted social life, right? So as nurses, many nurses value the close relationships with clients and coworkers, along with the diverse clinical experiences that evolve from caring from clients of all ages who have a variety of health problems, right? We're caring for clients for long periods of time, sometimes generationally within the rural communities. Okay. So Heather, does that help? Does that give you a better understanding of some nurses enjoy working in the rural community for all these reasons that are in the rationale. Others don't because of all the challenges. So that rationale gives you a good overview of the challenges of working in the rural community. When I send out the recording of this lecture, I'm also going to attach this document we're reviewing right now, because I want you to have a copy of this case study that has the answer and the rationales, because they're always good to review when you're preparing for exams. Okay. So the second question, what do you think? So she's working primarily with Mexican immigrants. What cultural health beliefs and practices is she expected to encounter when dealing with this population? So now this is a culture question about the Mexican population. Okay. So this rationale,
I would say D.
Pardon me?
Oh, I would say D for the answer.
Okay. So one of the things we're going to talk about throughout this class is, well, within migrant and vulnerable population, is you could be dealing and working with a variety of different cultures. This question is about the Mexican culture. So this rationale comes up is about the Mexican culture. So the answer is D, but let's read the rationale first. The nurse is considered an authority figure, right? And the nurse is considered an authority figure that should represent the individual. You should be able to relate to the individual, maintain the individual's dignity. So in this case, we're talking about a Mexican immigrant, right? So we should respect, be able to relate, and maintain the dignity. And here's some information about Mexican cultures. Mexican individuals prefer polite, non-confrontational relationships with others. Okay. The nurse should take measures to validate the understanding of these individuals. Right? Mexican individuals expect to talk about personal matters for the first few minutes of an encounter. They expect the nurse not to appear rushed and be a good listener. Humor is appreciated, and touch is a caring gesture that's seen as a positive behavior. Okay. So the question is, what might she expect in working with the Mexican population? All right, so we know A is incorrect. We know B is incorrect. Right, C is incorrect. We know the D, they may appear to understand the information you're providing them by nodding. Okay, so that's an overview of some cultural values, beliefs, practices of the Mexican population. Okay, let's go to number 3. I know you can see the answers, but let's talk about them. So here comes a man who's working in the grape fields for 12 to 13 hours per day. He's responsible for picking fruit, packing, moving crates, right? So what are some primary concerns for this client? Okay, well, C makes sense, right? If he's lifting 12, 13 hours a day, lifting heavy things. Well, we know D could be correct, right? Dust, chemicals, we know that that's a risk. We've already gone through that.
Skin cancer.
And then obviously skin cancer is a risk with him working in this setting. Right? So again, this is rural and migrant populations we're talking about. The physical demands of harvesting crops 12 to 14 hours a day takes a toll on the musculoskeletal system. Right? Back and neck pain were the most common types of chronic pain reported, with many workers leaving or changing jobs. Okay, naturally occurring plant substances or applied chemicals can cause irritation of the skin or the eyes. Green tobacco sickness, which is dermal exposure to wet tobacco, was experienced by 50% of tobacco workers that were working with that substance that were interviewed in North Carolina, which is where this case study came from. Eye problems can often be caused by chemical exposures, dust, pollen, lack of eye care because of the unavailability of the specialty resources in the rural communities. Okay, cancer is also a risk. We talked about that as a chronic potential chronic exposure to pesticides, right? So cancer is another cited risk, not well documented healthcare problem for migrant farm workers, mainly because of their exposure to the chemicals in the sun. Okay, so these three rationales in this case study reinforce some of the teaching we've done and the knowledge you've learned about migrant farm workers in the rural population. So, do you have a better understanding of these concepts, having gone through them in more detail?
Yes.
Yes.
Okay.
Yes.
Okay. Well, I want to be mindful of the time. It's 4:30. We didn't take a break. And so that concludes the lecture for today, but know that you can continue to reach out to myself, Dr. Kopteros, throughout the week until we get to next week. I'll put out some additional announcements, posting Dr. Kopteros's Zoom. I'll post that again, and that the additional Sunday concept review Sunday evening. Jory, do you have a question?
I do. I
Oh,
have
I
a
thought she
question.
was talking.
I
Go ahead,
do.
Elaine.
With that case study, the last one, we didn't choose Tractor Falls and we didn't choose the tobacco one. I can understand that that's the tobacco one because they're working with peaches and grapes.
Okay.
But the tractor, there's still a tractor going back and forth on the field to pick up these crates. Is that not considered a hazard that they may, because tractors are a big problem, one of the major problems that happen in rural
Okay.
areas.
I'm just looking back at the question. It doesn't address it addresses, I just looked at it real quick, but addresses he's on the ground picking the fruit, not that he's riding on a tractor.
Okay.
If it said he was riding on a tractor, that of course would be a correct answer.
Okay.
Of course. Yeah. Good clarification question. Does
All right.
anybody, you're welcome. You're welcome. Does anybody have any general questions that would benefit the whole group? Otherwise, go ahead.
I'm sorry.
Lauren?
I just want to reconfirm. You're gonna get back with us about tomorrow's exam review, whether it's 10 a.m. or 10 p.m.
No, I'm going to assume it's 10
10
p.m.
p.m.
I'm
Okay.
going to assume it's 10 p.m. unless you hear from me.
Okay.
Yeah,
Okay.
it's 10 p.m.
Yeah. Excuse me?
It is 10 p.m. The review.
10 p.m. Okay.
Mhm.
Okay. Thank you. So if anybody would like to stay on after to answer any specific questions, we are happy to stay on with you. Otherwise, I hope you have a good rest of the week. It was good to see you.
Thank you.
You're welcome. You're welcome.
Thank you.
Thank you. Have a good evening.
Yeah.